16th, and it gives me great pleasure to introduce my colleague, Varun Phadke, who is an assistant professor of medicine in infectious disease. Varun is a widely sought after educator, both locally and nationally, and is going to speak to us about medical education today. He holds multiple roles within the department and the medical school. He's a thread director in the medical school curriculum, an associate clerkship director in the medicine residency program. Associate clerkship director in the medicine clerkship, and an associate program director in the infectious disease fellowship. But nationally also, he's been named a fellow in diagnostic excellence for the Society for Improvement of Diagnosis in Medicine, as well as a contributing editor for the Human Diagnosis Project. Varun is very interested in clinical reasoning. I think we all recognize that clinical reasoning is a core skill as a physician, but I think many people from my generation approach clinical reasoning the same with the classic, Varun, the classic definition of pornography, which is you know it when you see it. But I think more recently, clinical reasoning has been understood as an area that has actually methodologic rigor to study it, and really specific steps that go into clinical reasoning, and understanding that allows one to teach, assess, and maintain skills in clinical reasoning. Otherwise, it's hard to help people improve when you just know it when you see it. So Varun is going to talk to us about that in his talk today, from inexperience to intuition, strategies to learn and teach clinical reasoning. And I am very excited to hear what you have to say. Thanks so much for joining us.
Thanks so much, Wendy. Can you see my slides and hear me?
We can, for both.
Okay, great. So thank you for that introduction, and thank you to the organizers of Grand Rounds for inviting me to talk about this topic, which has become very near and dear to me over the last couple of years. Before I get started, I have no disclosures. I wanted to start with this cartoon or image, and kind of these two rhetorical questions, which are, what is clinical reasoning and why talk about it? And the reason I want to bring up or raise these questions is to acknowledge really that clinical reasoning is an intrinsic part of being a clinician. It's not something that we acquire or learn at some stage in our training. It happens part and parcel of learning the biomedical knowledge and the epidemiologic knowledge and the therapeutic knowledge. And it's sort of infused in every aspect of the decisions that we make as clinicians, both diagnostic and therapeutic. And sometimes clinical reasoning can feel so automatic, so intuitive, as Wendy was sort of alluding to, that it seems almost kind of crazy to even think about it. It's like a fish literally asking, how is the water? Before I kind of give you my learning objectives for today, I wanted to sort of present three clinical or educational scenarios that hopefully at least one of which resonates with you, and use those to kind of frame this discussion about clinical reasoning and why I think it's important to talk about it in a very explicit way. So perhaps you're a teacher in the clinical setting, and you've thought to yourself at some point in your time working with trainees that their main struggle was, quote, not being able to put a case together. Perhaps when you encountered a clinical problem yourself for which you couldn't construct a robust differential diagnosis. If you're having trouble coming up with an example of this, I would suggest for most internists to think about the last rash that they saw for which they did not immediately identify what the cause of the rash was. And the last one is sort of speaking to my subspecialty colleagues. How have you ever signed off a case after ruling out the diagnoses in your own subspecialty, but without a good sense of what was going on with the patient and what really should be done next? How can you help the team further? And so hopefully one of these scenarios resonates with you as we dive into the discussion today. So my learning objectives, I'm first going to talk about the conceptual framework of clinical diagnostic reasoning and define some key terms that I hope become part of our shared language about this for teaching and assessment. I'll apply that framework to give you some very concrete strategies for more intentionally developing learners in clinical reasoning. And then just the last part of the talk, which will be the briefest part, is really to start a conversation with all of you and in our department about designing systems that improve the way we teach and refine reasoning to avoid bias and error. So let me start by talking about the framework of reasoning. So, as I said, we do and we see reasoning all the time. And as Wendy said, it is a little bit of we know it when we see it. Some of that is visual diagnosis, some of it is radiologic diagnosis, some of it is rapidly assimilating clinical cues like a lung mass and hyponatremia or fever in an intubated patient in the ICU, and reflexively being able to prioritize what we think is going on with the patient and what should we done next. And we are enthralled by good intuitive judgment. We flock to clinical case conferences, despite the fact that we are seeing patients day in and day out in our everyday practice. We carve out time to go to clinical conferences to watch other people reason through unknown cases. And some of this is a little bit of entertainment value, because I think expert clinicians in a sense, sometimes mimic what it feels like to watch a magician pull a rabbit out of its hat and come to a complex or unusual diagnosis with the same clinical information that we have, yet they're able to make a diagnosis with surprisingly high accuracy. And when we think about reasoning in this way, as this is what we do all the time, I think it's understandable to ask the question and for novice learners to be puzzled by when are we supposed to learn this? Or how are we supposed to learn this? And I think for a long time, the apprentice model has been sort of the way that we have taught reasoning, which is, you will watch me and you will hopefully learn the cues and thresholds that I use to make decisions and make diagnoses. And in a sense, this is really hard, I think, for novice learners, but also experienced clinicians who are seeking to improve their clinical reasoning to grasp, because really what you're telling everyone, or what we're telling everyone, sort of reflects this kind of now old joke about the young musician who's looking for directions to Carnegie Hall and keeps being told by the master musician to just keep practicing and you'll get there. And so one of the reasons that there is, I think, very little understanding about the explicit steps that go into clinical reasoning is that there's no formal curricula. So only 40% of medical schools have any curricular content focused on reasoning, and a lot of them are not systematic or standardized. There are no standard curricula for residency programs or medical subspecialty training programs in clinical reasoning. And as I've alluded to, clinical reasoning isn't a process that we only learn during our training. It's a lifelong process, yet there are limited opportunities for faculty development in CME. And so let's now dive into what clinical reasoning is and what are the component parts that we could use to teach this in a more effective way. So in a nutshell, clinical reasoning encapsulates the cognitive and non-cognitive processes by which we collect and interpret data to make diagnoses and management decisions. And I'm going to focus primarily on diagnostic reasoning in this talk. There is an emerging and rich literature about management reasoning, which I'd be happy to talk about with you separately. But we now know from a lot of studies from the 70s and 80s that clinicians approach cases diagnostically using the same exact process, and it's a process that is familiar to a lot of you, I'm sure. It's this process of hypothetico-deductive reasoning, which is the process of iteratively generating and testing hypotheses. And so if we diagram this process out, it starts with data acquisition from the patient, which is hypothesis-driven. Those data are synthesized into a problem that we name either explicitly or implicitly. We use that problem to search for solutions to the problem, and that's our differential diagnosis. And then we test those differential diagnoses against each other and verify either a definitive diagnosis or a working diagnosis. And you might ask, if the process is the same for experts and novice clinicians, why is there a difference in diagnostic accuracy? And I think that was a puzzle that investigators were trying to solve when they recognized that novice clinicians are doing the exact same process as experts, just not as effectively. And the straightforward answer to this is knowledge, right? So where do these hypotheses come from that we're using to gather data and interpret it? But I think what we have learned over the last couple of decades is it's not only the volume of knowledge that you possess, but it is the structure of your knowledge, the organization of it, and how efficiently you're able to access it. And to flesh this out for you, I'm going to talk about a couple of kind of theoretical underpinnings of expert knowledge structures. So the first is script theory and schemas, which is really a description of how experts organize their knowledge. And so the first term I want you to kind of hear about is illness script, which is a term which many of you are likely already familiar with. This is essentially a clinician's organized mental summary of a disease. It's sort of like a flashcard of the disease that exists in your mind. And that flashcard contains biomedical knowledge that you learned in medical school and beyond. It contains epidemiologic knowledge about risk factors for that disease, which you may learn in medical school or afterwards after your knowledge of the illness evolves after seeing patients. And it includes clinical manifestations of the disease. And you can see when you think about the component elements of an illness script, why there may be discrepancies, major discrepancies in the illness script of the same disease among different clinicians. So just speaking as an infectious disease clinician, my illness script for infective endocarditis is likely to be extremely different from the illness script of endocarditis in a psychiatrist, for example. And this is simply based on what we have encountered in our own practice, what we have read or what we choose to read, and what we are taught in our ongoing clinical practice. So just to give you sort of very concrete examples of this, here is how the richness of your illness script might vary between three clinicians. So pneumococcal pneumonia is an entity we see all the time. So your illness script may be as robust, your flashcard may be as dense as like the up-to-date article for this process. For a disease that we encounter much less frequently, like glycogen storage disease type 1, where you may never have seen it in your practice, or you admitted that one patient that one time. You may, your illness script may consist just of the bare bones from a Wikipedia page that you remember from medical school. Or your assessment or your synthesis of an illness script may be as rudimentary as just a list of items that cause metabolic acidosis without sort of any robust understanding of the individual diseases that comprise this list. So that's illness scripts, that's the content of our knowledge. But I'm talking to you about knowledge organization. And in expert clinicians, illnesses are organized very thoughtfully into diagnostic schemas, which are really cognitive tools that provide us with a structured approach to a clinical problem. So rather than simply remembering the 15 diagnoses that cause, let's say, jaundice, those diagnoses are actually organized in our mind in a very intentional way to help us activate that knowledge when needed based on data that accompanies the main problem we're trying to solve. And there are examples of schema for a variety of clinical problems. One very common schema that we learned early in medical school is the approach to abdominal pain and using the anatomic distribution of, where specific syndromes manifest in the abdomen as a way of compartmentalizing the list of things that can cause abdominal pain, which is otherwise tremendous and would be very difficult to remember or repeat on command. But if someone asks you, what is the differential diagnosis of right lower quadrant pain, it becomes much easier to generate that list. And we also have schema for non-pain problems, like in the example shown here, intrarenal acute kidney injury. So you can think about processes that affect the glomerulus, the tubules, the interstitium, and the vascular aspects of the kidney. And under those buckets, it's much easier to recall the specific illness scripts that you may need to consider in your patient. So schemas are essentially a tool to convert lists of related diagnoses into mental flowcharts that allow you to access that knowledge more readily. So that's how experts organize their knowledge. Let's talk about how they activate that knowledge. And to understand this, I'm going to introduce you to a framework called cognitive load theory, which may be familiar to many of you as well. So cognitive load theory, the premise of this theory is that human memory is divided into three parts. The first is sensory memory, which is really the instantaneous memory of all of our sensory input at any given time. So the capacity of this obviously is huge, but the duration is fleeting. We don't remember all of the sensory input that we're receiving at any given moment. That memory is filtered through working memory, which is the mind's scratch pad, which has a very limited capacity, a slightly longer duration than sensory memory, but still quite finite. One sort of vivid example of this working memory is, when someone tells you to remember a phone number or to call a certain phone number, and you're perhaps not interested in committing that phone number to long-term memory, but you are unable to remember it without constantly reciting it to yourself until the moment that you have dialed it. And then after you dial it, you actually can no longer remember the number. And that is how sort of finite the scratch pad is. And then memories go from this scratch pad to long-term memory, whose capacity is infinite theoretically, and whose duration is long, on the order of years, sometimes even a lifetime. So cognitive load theory sort of describes human memory in these three compartments, and says that cognitive load is basically the information that is presented to this stepwise processing of information. And the first thing you recognize if you think about memory in this way is that working memory is the bottleneck, right? So both sensory memory and long-term memory have a huge capacity, but to convert one from the other, data has to be processed. And where do we encounter this most frequently? Is on the wards when we're listening to case presentations, and we have to sort of extract the salient features of a case very quickly in order to activate the illness scripts that we have stored. And so how does this work? So when we first learn illness scripts and schemas, we learn them in this fashion. So if kind of following in the line of cognitive load theory. So here's a diagram of working memory and long-term memory. So let's say there are 7 items that working memory is able to process at any given time. And let's say those items happen to be these clinical features of a syndrome. So an acute febrile illness with headache and meningismus, with associated lymphocytic pleocytosis in the spinal fluid. This is a self-resolving syndrome and usually is associated with viral etiologies. And this is when we all learned in medical school, this constellation of things is equal to viral meningitis, and it's locked away in our mind in that sort of encapsulated form, alongside a variety of other illness scripts that we have stored. So then when we're hearing a case presentation, which contains a lot of clinical data, we need to extract just the salient features very quickly in order to activate that information efficiently. So what happens? So here we are, our working memory is blank until we start hearing the presentation, and we start to pick out key features of the case based on the presentation that we're hearing. And we use those key features like a search engine. We type them into the search engine of our mind, the working memory, and that activates the script that contains those key features. And we bring viral meningitis as that entire encapsulated concept into our working memory. And we can actually bring forth other entire encapsulations of diseases based just on those key words that they share: fever, headache, and abnormal CSF. And that's what allows us to rapidly generate a differential diagnosis of these fairly complex concepts that contain pathophysiologic information, clinical information, epidemiologic information in real time, just based on a very small amount of clinical data. So this process of identifying clinical salient features that activate knowledge efficiently is called problem representation, which is essentially a succinct mental model that highlights the defining features of a case, and is really the clinical problem you are solving or that you need to solve. And it contains 3 elements. One is patient descriptors like epidemiologic risk factors, age, biological sex. It includes time course, like how the disease began and how it has evolved. And it includes clinical features, which you have deemed to be relevant, like dyspnea or chest pain rather than toe pain and pruritus. And to illustrate for you the power of framing diseases very intentionally to activate knowledge most efficiently, I just want to show you how things as simple as age and biological sex and clinical risk factors immediately start to prune the differential diagnosis for these common clinical problems like melena or abdominal pain or chest pain. And this is so automatic, this process of framing that we engage in, that sometimes we fail to take the time to explain explicitly how these individual elements of the problem representation are guiding our diagnostic thinking to early learners. Onset and tempo similarly can be used to refine the differential diagnosis very quickly by activating knowledge in a very specific way, right? So hyperacute chest pain has a very different differential diagnosis than chronic chest pain. The same is true of progressive dyspnea versus intermittent dyspnea. And the final aspect of the problem representation is the clinical features. And there are two sort of ways that we describe problems that I think are worth me mentioning here. One is the use of semantic qualifiers, which are really adjectives that are binary modifiers of clinical data. And we've talked about some of those already, like acute and chronic, like time course, but unilateral and bilateral would be another example for pain or edema, painful or painless for jaundice, for example, inflammatory and non-inflammatory for arthritis. There are many. I'm sure that you, in your individual specialties, can come up with any number of semantic qualifiers that you use to rapidly sort through all of the illness scripts and schema in your mind. And then encapsulation is when we compile all of the symptoms and signs into a single pathophysiologic entity, sort of as I did with viral meningitis, to more rapidly assimilate new clinical data. So for example, on hospital day 3, Mrs. Smith, who you admitted 3 days ago, is no longer the patient with dyspnea on exertion, orthopnea, lower extremity edema, JVD, and elevated BNP. She's the lady with congestive heart failure. And so when the team tells you that that day the patient has hyponatremia, you assimilate congestive heart failure with hyponatremia, and that's the problem you're trying to solve, rather than dyspnea on exertion, orthopnea, lower extremity edema, JVD, elevated BNP, and hyponatremia, which is very taxing on working memory. And so just to illustrate this for you, I'm going to give you a clinical vignette and sort of evolve it over time and help you see the power of this process for developing a differential diagnosis. So here's a 24-year-old man with no medical history, presenting with fever, headache for the last 10 days, found to have neck stiffness and cervical lymphadenopathy on exam, with spinal fluid showing elevated white cells that are mostly lymphocytes and protein with normal glucose. You think for a moment about your differential diagnosis. Now let's just recast that same data using semantic qualifiers. This is a 24-year-old previously healthy man with fever, subacute occipital headache with photophobia, found to have meningismus, cervical lymphadenopathy, and spinal fluid showing lymphocytic pleocytosis. You already begin to understand the power of using these terms in a more translated way. And then you could go even further and encapsulate all of this data into a 24-year-old man with aseptic meningitis. And this allows you to assimilate other aspects of the case easily, which is what we do as experienced clinicians. So rather than hearing the entire vignette as I first posed it to you, now you can focus on, oh, this is a 24-year-old man with aseptic meningitis with recent travel to New England. Or this is a 24-year-old sexually active man with aseptic meningitis. Or this is a 24-year-old man who recently started NSAIDs who presents with aseptic meningitis. It allows you to encapsulate new clinical data more easily when you have grouped the clinical data in this way. So just to recap, the 3 terms that I talked about were problem representation, diagnostic schemas, and illness scripts. And many of these terms may already be familiar to you, but I think it's helpful for us to have a shared understanding of what they mean. And so if we revisit this diagram of the diagnostic process, we can fill out the different components a little bit more. So after data acquisition comes problem naming, which is really the problem representation. Hypothesis generation is differential diagnosis using stored schemas and scripts. And hypothesis verification is the process of directly comparing and contrasting illness scripts to find the best fit. And so this is the explicit diagnostic process that has come to be described over the last decade or two for how expert clinicians think. And you may be thinking to yourself at this stage in the grand rounds, like, this is a great description of clinical reasoning, but so what? What am I supposed to do with this information? So that brings me to my second learning objective, which is to talk about how to apply this framework to more intentionally coach our learners. So before I dive into a couple of specific clinical scenarios, I wanted to give you a frame using this tale of three clinicians, which is actually taken directly from the citation on the slide here. So you have three clinicians who encounter a four-legged beast that looks like this, and their job is to diagnose what this beast is. So the first clinician, whose name is Pat Reck, says, it looks like a dog I saw once before, it's a dog. So what did this clinician do? This clinician engaged in pattern recognition or skilled intuition, really. And this is a hallmark of experienced clinicians. We have seen a lot of different diseases and the varying manifestations of them. And it's quite easy for us to pull from our memory an episode of the same illness presenting in a very similar way or in a very similar patient and rapidly come to that diagnosis. In fact, the diagnosis comes to our mind effortlessly without any awareness of the cues that triggered the diagnosis or any explicit assessment of the validity of those cues. And this is sort of getting at what Wendy described, this idea that you know it when you see it and you know it in someone else when you see it. And I think a lot of clinical reasoning, especially for simple problems, occurs like this. So if I show you these 4 one-liners for patients, I'm sure that a single solution or a very short list of solutions comes to mind for any one of them to explain just a tiny amount of clinical data for each of these clinical vignettes. Now, another clinician approaches this same beast and says, well, it has 4 legs, floppy ears, and it weighs about 20 kilograms. It barked a minute ago. It's furry. It must be a dog. So what did this clinician do? So this clinician engaged in a very explicit diagnostic process, as I have sort of been outlining. Maybe dogs are unfamiliar to this particular clinician, and the solution was not immediately obvious based on the clinician's prior experience. And so the clinician had to actively seek out cues, verify them, examine them for their relevance among the illness scripts and schemas that exist in their mind from their reading and from what they've been taught, and to sort through them and prioritize what they think is most likely. And this is, I think, the process that we engage in when we encounter an unfamiliar problem or a complex problem. And so here are some examples of these problems. So a patient with a cavitary lung lesion and rash, or fever in a patient in the intensive care unit, hypoglycemia in a previously healthy patient with palpitations, chronic intermittent abdominal pain with normal imaging. There's not an immediate solution that comes to mind for any of these scenarios. And so we have to go through a very deliberate, effortful process of finding the cues, verifying them, and determining whether they are relevant to identifying the solution to the problem. So the final clinician in this tale is Hypo D Duck, who recently arrived from the Aleutian Islands and has only actually encountered husky dogs in their past. And this person says, it might be a dog because it has 4 legs, a tail, and floppy ears, but on the other hand, it could be a baby polar bear because it's white, and I thought I heard it growl a minute ago, so maybe it's a wolf. And so, you immediately recognize that this learner, this particular clinician is having some struggles with this case. But before I get into what the struggles might be, the first thing I want to point out is that all 3 clinicians appropriately prioritize the correct diagnosis. Now, their confidence in that diagnosis may be different, but they still got the diagnosis correct. And the reason I emphasize that is because diagnostic accuracy is a measure of reasoning ability, but not the only measure. because any one of these three clinicians could have serious deficits in their knowledge or knowledge organization or knowledge activation. And if we based our assessment of their reasoning skill just on if they get the diagnosis correct, we would be missing something and missing an opportunity to develop that clinician further. So how do we help this last learner? So one approach would be to kind of use the elements of the diagnostic process that I've talked about to be very intentional about our intervention. So here's that diagnostic process again, and I'm going to focus actually just on two aspects of this. One is problem representation. So here's a scenario that is probably familiar to all of you who have rounded with trainees in the clinical environment. You're rounding with your team, your learner presents the case, and I'm sure I have done this, I'm sure many of you have uttered the phrase, next time just focus on the pertinent data. And in your mind, what's going on in your mind is, they're just not putting this case together. And that could be because you've reached a conclusion that they have not yet reached, or they have reached a conclusion that you have not yet reached. Perhaps they're having premature closure on the case. And the fundamental problem here is that there is a discrepancy in the problem that you're trying to solve. And this is a problem representation issue. So what are some ways that we can explicitly remediate this issue or coach our learners? And in order to do that, we have to understand the steps that go into problem representation. So the first is naming the problem appropriately. And we talked about semantic modifiers. So here is the universe, for example, of things that cause dyspnea. And this is a relatively abbreviated list of the things that cause dyspnea, but it's kind of disorganized, but you can sort them pretty quickly using these binary semantic modifiers, right? And you actually have even more diagnostic power when you combine these semantic modifiers together. So what are the causes of dyspnea that are abrupt onset that present with a normal chest x-ray? Or causes of dyspnea that have subacute onset with an abnormal chest x-ray? That combination of semantic modifiers is very powerful at refining the differential diagnosis, even if your learner has a rich library of illness scripts already. We actually do that. We actually have opportunities to do this from a very early stage. So we teach medical students the locate mnemonic to make sure that they gather a comprehensive history from the patient, especially when it comes to pain complaints. And the opportunity here is to move just from them gathering a descriptive history about the patient to linking each of the components of locates to semantic modifiers that actually are effective at activating knowledge, right? So don't only identify where the pain was, but use the exact semantic modifiers that we use to encode knowledge in our minds to teach them how to gather a history in a hypothesis-driven way. The same can be said for the character of the symptom or the aggravating and alleviating factor, the timing and the severity, and so on. So are there data that doing this actually helps? So comparing novice and expert clinicians, in think aloud exercises, experts use more semantic qualifiers than novices to describe the same case. Learners can be taught to maximize their use of semantic qualifiers with basic interventions like workshops over the course of a preclinical curriculum or within a single clerkship. And the use of semantic qualifiers has been associated with increased diagnostic accuracy, even at the same level of learner, meaning learners who possess the same library of illness scripts, when those who use more semantic qualifiers have better diagnostic accuracy. And why does this work? It works because we encoded the knowledge in long-term memory in an ideal world using the exact semantic modifiers that we want our learners to use when describing new cases. So the best way to activate that prior knowledge is to use the same terminology that we used to encode it in the first place. That makes the search engine more effective. It's sort of like thinking about mesh terms in PubMed. They work because that's exactly how PubMed is indexed. Now, we all know that naming the problem effectively is useful, but not sufficient for effective reasoning. And the best illustrative example of this, even for experienced clinicians and internists, is when we think about rash, right? So, our tendency as internists is to describe many types of rash as maculopapular. And I'm sure all of you, like me, have attended dozens of hours of CME sessions with dermatologists to learn how to name rashes better. So yes, maybe I should have described it as a pruritic, non-tender, round patch of eczematous dermatitis with some scale. But does that make me better at diagnosing the rash? No, it doesn't. I get better at naming things, but my library of illness scripts for the rash and my schema for the illness script is no better. So not only do you need to know how to name the problem, you need to know what the contents of the problem should be. And so this introduces the concept of identifying what aspects of a case are signal and what aspects of a case are noise. And it's worthwhile being very explicit about this, even as experienced clinicians, because learners may not have a good understanding of what is signal and noise. So the concept of signal and noise comes from signal detection theory, which is really a theory that arose to describe the performance of radar operators and how well they could discriminate between ships and other objects in the ocean. And what this theory describes is that the test operator must be able to not only detect the stimulus on their radar, but then they must be able to interpret the stimulus as either signal or noise. And what the theory has determined is that the two principal features that influence the performance of the test operator are the intensity of the signal itself and the psychological state of the operator. So how does this translate into the clinical setting? So here is, a bedside scenario, and I've taken this picture from the Stanford website to find a master clinician who many of you will recognize, Abraham Verghese, with a group of learners. And I will say that the vignette that I'm going to describe right now has nothing to do with the learners or Dr. Verghese pictured here. I just thought it was a good photograph. So here's a patient who's being presented at the bedside who was admitted with chronic cough. And the learner who's being put on the spot to figure out, why does this patient have chronic cough is processing a lot of stimuli, right? So the alarm keeps beeping because the patient is mildly hypoxic. The patient keeps talking about their left arm tingling. The overnight resident gave, the ins and outs in excruciating detail. The student who presented the case on rounds is mentioning a lot of laboratory abnormalities like hyponatremia, hypokalemia, a variety of others. And parsing through all of these data is cognitively taxing. And I think this is a challenge for early learners, but also experienced learners. And recognizing that this is a challenge and recognizing that through our experience, we are able to weed through this noise more easily and efficiently, and why we're able to focus on just salient aspects of the case that are able to render the diagnosis with high specificity is something that we should recognize and be very explicit about when we're teaching about cases, rather than just asking learners to say, why are you not coming to the same conclusion as I am? We need to be more explicit about what are the cues that made me come to that conclusion. And this is why I'm sure many of you remember rounding with an experienced or master clinician. And you'll remember that master clinician saying, this clinician has weeded through all of this noise and has decided, oh, this man has a chronic cough, weight loss, hyponatremia. I'm wondering about an undiagnosed lung malignancy. And maybe this left arm tingling is actually a superior sulcus tumor from small cell lung cancer causing hyponatremia. And so, how did this learner not notice the hypothenar wasting in the left hand? Well, the learner may not have even thought to look for that because they were so bogged down in the other noise of the case. The other sort of scenario in which this arises is when the master clinician steps out of the room and asks the team, what book did he have on the bedside table? How is it possible for the learners to absorb these signals when they're having trouble weeding through all the noise? So what are some factors that influence when we retain data as signal? And this is taken directly from the citation that I've shown on the slide here. So obviously the intensity of the signal. So how abnormal is the signal? That comes directly from signal detection theory. But then the psychological state of the operator. So does the data point match an illness script that I have in my mind, right? So plenty of patients complain to us about dark urine, and quite often we ignore it, right? but dark urine in a patient on a new medication for hyperlipidemia activates statin myopathy quite quickly and rhabdomyolysis, and we retain that as signal. We also retain data points that help us discriminate among illness scripts very easily. So chest pain reproducible on palpation very neatly divides causes of chest pain, and so we retain it as a data point. And then finally, data that we foresee as the solution to the problem because of our deeper pathophysiologic knowledge or pathophysiologic reasoning about how diseases evolve. So, a patient complaining of toothache, maybe, you may not think much of the toothache, but a patient with multifocal cerebral emboli, all of a sudden that subtle toothache that the patient was noting has clinical significance because it may lead you to the solution to the problem you're trying to solve. So what are some strategies to teach problem representation more concretely using what I've just shown you? So the first is to show how to name problems in an iterative fashion very explicitly. So on the left side here, I've shown the same case, how it evolves over time as you gather historical data, physical exam data, social history data, and showing learners how you are naming the problem in your mind in an iterative fashion to navigate the differential diagnosis is very powerful. Reframe the problem using data that you have decided are either signal or noise as a probe for the content and organization of the learner's knowledge. So how does gout change your differential for sore throat? Should we even include it? Maybe it does change it, and what does that make you think about, and so on. And then finally, reflect on alternatives. And I think this is a great strategy for lifelong learning, always reframing the case with new or different data to see if you can come up with a different differential diagnosis or if it activates knowledge differently for you. And this is a great way to avoid anchoring bias or premature closure on a case. So that was problem representation. I'm going to turn now to briefly to hypothesis generation and teaching schemas. So here's another scenario, and I'm sure many of you have uttered the phrase, you need to focus your differential diagnosis more when you're working with a learner. Or the flip side, you need to have a broader differential diagnosis. And what you're really getting at here is that the learner's approach to the problem is inefficient, unstructured, or incomplete in some way. And what you're really getting at is that their schema is not effective or complete. And I already talked to you about what schemas are. They convert the list of diagnoses into a mental flowchart, but it's helpful to think about the component pieces of schemas as a way of understanding how we can teach them more effectively. So here's a diagram of a schema. So at the top is the clinical problem you're trying to solve. Beneath the problem are branch points or pivots in a case. Within each branch is a category of diseases, and within each category are individual diseases or groups of diseases. So just to give you a very rudimentary schema for a problem we think about a lot on infectious diseases, leukocytosis, right? So patient has leukocytosis, and perhaps you decide to use fever as your branch point. And if they have a fever, you're thinking more that this is an infectious cause. If they don't have a fever, you're thinking more of a non-infectious cause. Now, certainly this is not meant to be an accurate schema in any way. This is just meant to be illustrative of what a schema might look like. So are there any data that using schemas differentiates novice and expert clinicians? And the answer is yes. So in think aloud exercises with unfamiliar cases, experts more frequently invoke schema-based disease representations. Learners that experience schema-based teaching report decreased cognitive load and more effectively identify pivot points in a case that render the diagnosis more efficiently. And this is the explanation for why experts gather less data, but actually make the diagnosis more accurately than early learners who gather a ton of data, but still come to the incorrect conclusion. And finally, the use of schema-based instruction correlates with increased biomedical knowledge retention and diagnostic accuracy. So how can we teach schemas more effectively? So if we use this rudimentary schema that I showed you as an example, the first is to teach clinically relevant schemas. And what that means is the branch points in the schema should be specific to the problem you're solving and representative of the steps that you actually follow when you solve the problem. So a great example of this is a mnemonic that students often learn called Vindicates, which is a mnemonic for remembering the categories of diseases that cause illness, right? And the Vindicates mnemonic is problem agnostic. You can apply Vindicates to dyspnea or fever or jaundice or whatever it might be. But it's not really helpful because it's too comprehensive. It's not prioritized in any way. So you need to have the pivot points in your schema relevant to the problem. The second is that the pivots have to be representative of what you're actually going to do for the patient. So as an example, for jaundice, for which many of us have a shared schema, one of the reasons one of the first pivot points is direct versus indirect hyperbilirubinemia is because that's one of the first things we do. We fractionate the bilirubin. Once we determine that it's direct hyperbilirubinemia, the next branch in the shared schema is extrahepatic versus intrahepatic, because that's what we do. We obtain an abdominal ultrasound to look for biliary ductal dilatation. And so schemas that are problem specific and representative of the steps that we actually follow are most useful. So in the case of this leukocytosis schema, it might be helpful to divide it by, what is the predominant cell type, because, we obtain a diff after someone has unexplained leukocytosis, and that helps you prune the differential diagnosis further. The second strategy is to build on and revise existing schemas. So you don't have to build your schemas from scratch. There are plenty of published schemas out there, but you can add to them. And this is your opportunity to infuse schemas with biomedical knowledge. So in this case, perhaps instead of dividing neutrophilia by infectious and non-infectious, think about the compartments where neutrophils hide, the bloodstream, the extravascular space, the spleen. And that biomedical sort of addition to the schema helps you think about disease entities that don't fit neatly into infectious versus non-infectious, like hyposplenism, for example. And the third way to teach, to improve schemas is to foster contrastive learning. So your goal is really not to make people experts at one disease, but to make people experts at differentiating between diseases. And so instead of telling people to simply read more, we should be telling people to read better, read across illnesses by the same data point, like what does the epidemiology of PE versus pneumonia versus asthma look like, or the time course of hemolysis versus primary biliary cirrhosis versus alcoholic hepatitis as a cause of jaundice. So that was applying the framework to this diagnostic process. And the one thing I will say here is this process, and what many of you are probably thinking is, process isn't everything. And I think a good way of capturing this is a quote from a paper that I've cited here, which is, if you've not heard about myasthenia gravis, you cannot reason your way into that diagnosis. Similarly, you can spend all day collecting more and more information from a patient with fatigue, but if you don't have a good illness script that contains atypical manifestations of heart failure, you're never going to recognize that it's heart failure. And so in the realm of expert diagnostic performance, knowledge is king. And so that brings me to the final objective here, which is how can we blend our intuitive sense that knowledge and experience are critical for developing good reasoning skills with our understanding that process is also so vital. And that brings me back to the final aspect of this tale of three clinicians, which is this clinician at the top who got the answer right away. And what did this clinician do? What is the expertise possessed by this clinician? And in the literature, it's described as intuitive expertise. And that could mean a variety of things. It could mean that this clinician has a really great illness script for this particular dog, or has a really good schema for differentiating between dogs and other animals. But what it probably means for most really experienced clinicians is that they have a rich and diverse library of instance scripts, meaning this person has seen a ton of different dogs, including this dog, and a ton of other closely related animals for which it could be mistaken, and has the ability to extract with precision the instant script that matches this unfamiliar case the best. And so, we come back to, is the solution to remediating this learner simply to have them go out and look at a lot of dogs and work out their similarities? And this is, what boils down to let's get people to spend more time seeing patients. Let's have them read more. And my argument here, after going through the diagnostic process for you, is that we have to have conditions for developing this intuitive expertise that can be much more intentional. And over the next couple of slides, I'm just going to pose some rhetorical questions just to start a discussion in this group and in our department about how can we use our knowledge of this process to more intentionally develop the knowledge and experience that our learners have in the clinical environment when it comes to volume of cases, diversity of cases, and feedback they get on cases. So for volume of cases, it's just not a matter of seeing as many patients as you can, it's seeing them in a way that you're cognitively able to process them and that you're being coached in an effective way. So here's a question. Is it more effective in clinical problem-solving case conferences to showcase just one clinician navigating one really complex case, or to have multiple clinicians discussing several related, perhaps simpler cases so that they can learn from each other's schemas? How should we curate subspecialty rotation experiences so that learners are seeing an adequate number of the cases that we want them to see in our subspecialties? In terms of diversity of cases, a question I'll pose to my subspecialty colleagues: what proportion of the cases presented as unknowns in your fellowship programs are outside your specialty? How well are we developing the illness scripts and schema of our learners if we never let them see and learn about with any rigor the diseases that mimic the diseases that they're going to be caring for? And how much could that benefit our ability to consult on cases that end up not being within our subspecialty? And finally, feedback on cases. How can we get our EMR to make getting feedback on cases easier and more systematic and less me spending time after I've gone off service to manually hunt down all the patients that I took care of and figuring out what happened to them? How can we optimize feedback from night float rotations or other rotations where the time of patient contact is limited? Or how should subspecialists get feedback on the patients that they sign off of in a systematic way? So I don't have answers to these questions, but I look forward to hearing a discussion about it. But I'm going to close with just a summary here. So clinical reasoning is a skill that blends knowledge and experience with a very explicit process, and that process is accessible to both novices and experts. And knowledge of both is necessary to become expert. I think knowledge of the frameworks that I've talked about, like script theory, cognitive load theory, signal detection theory, helps us become better teachers of reasoning by forcing us to be very explicit about the things that are guiding our thoughts about a case, but also learners of reasoning and how we can refine what we already know. And finally, experience can lead to good intuition. I don't deny that whatsoever, but I do think we can be more intentional about systematically facilitating that transformation in our learners and in ourselves. So I just want to acknowledge, again, Wendy and the Department of Medicine for supporting my passion in this area. I did want to mention Jennifer Spicer and Meredith Laura, who I've talked to at length about these topics in many different venues, and have helped me come to this sort of very refined sense of this content area, as well as some mentors that I've identified outside of Emory in the world of diagnosis, and the Society to Improve Diagnosis in Medicine for inviting me to be a part of the Fellowship in Diagnostic Excellence this year. So with that, I'm going to stop and take any questions in the last few minutes that I have.
Thank you so much, Varun. And everybody feel free to put questions in the chat. I think that I'll start out and I'll say that I think there are a lot of seasoned clinicians probably in the audience here who have fairly intuitive sorts of reasoning styles. And what would be, so you've obviously given us a lot to think about. What would be sort of steps to, to start to be better about either improving our own reasoning skills or transmitting that? And is that to start looking at schemas that other people have made to try and organize our thinking in a different way? And are there resources that you would suggest, or is there a different strategy that you might use as a starting point?
Yeah, no, so I think that's a great question. So I think there are many schemas that, or many resources for schemas that exist, and there are textbooks, like there's a text that many of you are maybe familiar with called Frameworks for Internal Medicine, or Symptom to Diagnosis for earlier learners. There's a now well-known podcast, The Clinical Problem Solvers, who have made it a business of making schemas. And I think using pre-existing schemas is one way to sort of graft your existing approach to a problem and make it available to learners. The one thing I will say is that sometimes it can feel unnatural to pull someone else's schema and say, like, well, I don't really think about the problem in this way, but here is a way to think about the problem. And so I think the very first step, and this is what I talk about whenever I'm doing like a development session about how to teach reasoning, is, every case that you see and process, pausing, slowing down, and being very explicit about, why am I already thinking about X illness to explain this person's symptoms? What cues already led me to think about that? So, I'm seeing a patient on the infectious disease service with skin lesions, and I'm instantly thinking, even before I rounded with my team, like, oh, this could be a disseminated X infection. But why am I thinking that? Is it because of the speed that it presented, or the appearance of the lesions, or the host that I'm taking care of? And being very explicit about identifying those cues, I think, is the first step in helping our learners get to our level.
I think we have time for one more question, and there's a couple that revolve around this sort of the same idea here. And so I'm going to take Dr. Lee's question. So he notes that the ABIM knowledge check-in lets you use up-to-date during the test, or our residents, students all have access. All of us have access on our smartphone to immediate information. You mentioned that knowledge is king in diagnostic reasoning. Given this, what is appropriate or not in the use of point of care resources when precepting learners or teaching diagnostic reasoning? Does that create shortcuts through the appropriate steps?
Yeah, no, so I think that's a great question. And I think one of the reasons many of us are drawn to clinical reasoning is because it really is the aspect of being a clinician that is not offloadable to a device or to the cloud. Because the cloud has the illness scripts and even the schemas, but it doesn't have the data gathering step. And I think that there is a certain amount of kind of pure raw knowledge that our learners need to possess in order to reason through cases effectively. I think, Jerry, to answer your question directly, I think the best way that I found to address this question is I ask the learner, what do I need to do, or what am I thinking about this patient in this moment that a resource would not necessarily help me decide on. So let's say you're seeing a patient in the clinic and you need to decide, am I going to admit this patient? Am I going to do a workup for the patient today, like order a stat test? Or can I wait a little bit and see how the disease evolves? And it doesn't matter what you look up about the diseases. There's a threshold that is in your mind that is guiding which one of those pathways you're going to go down, and that is clinical reasoning. And using that as the starting point for a conversation about, what are the thresholds that you're using to determine how likely a particular disease is a great way of helping learners see, like, even when you go to those resources, what are the key pivots that you should look for.
Thank you so much, Varun. I think we are actually we're a little bit over time, so I will stop there. But this has been extraordinary. Thank you so much.
Absolutely. Thank you. And thanks everyone for the great questions.